you are welcome. And I just want to confirm that you can hear me. Maybe Agnes, you can confirm.
We can hear you, Prof.
Thank you so much. So we are here lucky to have quite a very topical topic, which is scaling up integrated management of newborn and childhood illness strategy in Uganda. And we are going to be sharing lessons learned in Uganda. My name's Peter Waiswa, and I'm an associate professor at Mackay University at the School of Public Health in the College of Health Sciences in Uganda. And I'm also a visiting researcher at Panelist Institute. And I'm a member of actually the task force, the Child Health Task Force Coordination Committee that is organizing this meeting. In today's presentation, we are going to be joined by one presenter and 4 panelists, whom I'm going to be introducing shortly. Our main speaker is going to be Ms. Agnes Namagembe. Namagembe is a maternal child health specialist at FHI 360 under the Maternal Child Health and Nutrition Activity Project in Uganda. She's a public health specialist with 10 years of work experience in the field and she graduated with a Master of Public Health from Mackay University. She was actually my student. She has also served as a technical officer, coordinator, and a specialist for various international organizations and supported national and subnational level efforts towards the update, development, and rollout of a number of guidelines, strategies, tools, and high-impact interventions. Agnes has a great skills and experience conducting capacity building initiatives from frontline health workers. So Agnes is going to be our presenter, and one of our panelists is Dr. Bodo Bongomin, who is currently the National Professional Officer, Child and Adolescent Health at the World Health Organization in Uganda. He is trained as a pediatrician and is a child and adolescent health specialist and advocate, and holds a master's in public health from Leeds. He promotes evidence-based medicine and also a specialist in vaccinology with over 11 years of experience in the field. He has also served as a lecturer and a consultant advisor for various international organizations, including the UN, where he works. Our third presenter is Dr. Jessica Nsongwa Sabiti, who is currently the Commissioner Maternal Child Health in Uganda. She's a pediatrician with over 30 years of experience in the field and holds a PhD in public health from Karolinska Institute in Sweden in health systems development. She has also served as a consultant advisor for various international organizations and spearheaded the development and rollout of a number of policies and high-impact interventions. We call Jessica actually Mama IMCI in Uganda and the region. Our last panelist is Dr. Emmanuel Mugisa, who is currently a program management specialist for child health and nutrition at USAID Uganda. Emmanuel is a public health physician who holds a bachelor's degree in medicine and surgery and a master of public health, both acquired from Mackay University, Uganda, again from our university, as well as a postgraduate diploma in project planning and management from Uganda Management Institute. He also served as a technical officer, advisor, and the coordinator and manager of several international programs. Welcome to our speaker and the 4 panelists. In terms of background, as you might know, that the Child Health Task Force has one main job, really to advocate, but also to build capacity for countries to make progress around accelerating progress for children 1 month, or can we say 0 month to 59 months, but with a special focus on infants and children. So that, because despite the progress in countries, many countries are still behind, and the kind projection that most countries might not achieve SDGs if they don't accelerate the progress. Uganda has made a lot of progress and is actually an exemplar in child mortality reduction. But we still have newborn mortality as a big issue, but still some job to do even for these older kids. The lessons in Uganda are important to also other countries that are struggling to implement the reductions. So IMCI is one of the key strategies that countries need to use. Developed in the 90s, it still remains relevant. Our first presenter today is going to be Ms. Agnes. And one of the things that we'll be discussing, the relevance of IMCI in the new changing life course approach to child health or child health redesign that is going beyond survival to look into thriving and the transformation. So I'm going to invite Agnes to make her presentation. Over to you, Agnes.
Thank you very much, Dr. Peter. Good morning, good afternoon, and good evening to you all. My name is Agnes, and I'll be sharing Uganda's journey of scaling up integrated management of newborn and childhood illnesses strategy. This is a graph of trends of childhood mortality from 1989 to 2016, which is the latest demographic survey data available. And we see a steady reduction in under 5 and infant mortality. However, neonatal mortality remains stagnant. Our institutional mortality data shows us that the mortality burden remains high. And the most recent neonatal mortality rate is 20 deaths per 1,000 live births, yet the under 5 mortality rate is 46 deaths per 1,000 live births. And as the bars show, this still exceeds the global and national targets. Key to note is that the leading causes of under 5 mortality are malaria and pneumonia. However, we've seen big drops in causes of under 5 deaths due to diarrhea, severe malnutrition, and pediatric HIV. In 1995, Uganda selected the integrated management of childhood illnesses as a key strategy to reduce morbidity and mortality associated with common childhood illnesses, and has since incorporated additional guidance on management of fever, HIV, newborns, and possible severe bacterial infections where referral is not possible. I'm now going to share some of the key lessons learned as a country in scaling up IMNCI. The first lesson is around adapting a suitable training model. Scaling up coverage of high impact interventions for common childhood illnesses has always been and is a priority for the Ministry of Health in Uganda. And that's why in 1996, Uganda adopted the 11-day IMCI training. However, challenges associated with this included, it was a long training associated with high costs. It also took health workers away from health facilities, hence causing disruption in routine services. This coupled with transfers and high turnovers common in our private sector made it difficult to sustain IMCI capacity at site level. The challenges are not unique to Uganda alone. And that's why in 1998, WHO developed the computer-based adaptation and training tool, which was later adapted for IMNCI in 2008. Similarly, Uganda adapted and rolled out ICAT in 2015 to 2017. And this was to set stage for the introduction of modified courses for capacity building. Efforts were also made to attain learning from Tanzania that had earlier initiated the rollout of the WHO distance learning course. So this saw the Ministry of Health, together with these stakeholders, develop, adapt, and pilot 2 modified training approaches. That is the short interrupted course as well as the distance learning course. The targeted cadres for the training included pediatricians, medical officers, clinical officers, nurses, as well as midwives. Regarding the evolution of IMNCI training in Uganda, we note that since 1996, we've seen changes in the training modality, starting off with the original 11-day training approach to integration of IMCI in pre-service courses for medical students as well as nursing students. I also want to point out that IMCI was incorporated into the mainstream support supervision system. And as earlier highlighted, abridged models were piloted and have been since used to scale up IMCI countrywide. Let me tell you a little bit more about each of the training models that Uganda considered. The first being the IMCI computer-based adaptation and training tool. This is a site-based training in that it takes place at the health facility. It is a self-study model delivered using a computer. And what actually happens is a support person comes to the health facility and sets up the computers, as well as orients learners on how to access modules on the computer. The learners then in their own time study the modules, and this takes about 2 weeks. The key inputs required for this module are a computer and electricity. And I want to point out the strength of this model, which include the fact that it was relatively cheap because it was on site, and more importantly, it minimized disruption to service delivery. The key limitations around this was the low computer literacy levels among healthcare workers, the limited access to computers, lack of reliable power supply affecting computer use, and inadequate support materials to aid effective learning. All in all, the ICAT module was used in 15 out of 146 districts in Uganda, and 123 health workers were reached. Moving to the distance learning model, this uses a hybrid modality that involves participants convening at a centralized offsite location for face-to-face facilitator-led sessions. Participants are convened for 3 face-to-face sessions, each allocated 1 day with 2 breaks in between. So the first break runs 3 to 4 weeks, while the second break runs for 8 to 9 weeks. During the self-study period, trainers make an effort to follow up trainees to provide them with mentorship support coupled with interactions using social media. And for our case in Uganda, we used WhatsApp. It was available at the time. So it takes about 84 days to complete this course. And the key inputs are printed materials as well as trainers. I want to highlight the strength of this model in that it's cheaper compared to the 11-day original training and equally minimize disruption in service delivery. Also, the phased learning allowed participants time to grasp, internalize, practice what they had learned and put it into, in their own setting. Limitations include the longer periods to complete the course. Hence, some participants dropped out along the way. Also, the low-level cadres struggled to internalize content on their own. This coupled with the low reading culture in our country. In summary, this model was used in 2 out of 146 districts in Uganda, and 235 health workers were reached. Now, I'm going to tell you about the third model, which is the short interrupted course. This utilizes a hybrid modality that involves participants convening at a centralized offsite location for 2.5 days, during which they are taken through some training modules and are each given additional modules for self-study. Participants then break off for 2 weeks of self-study and case practice at their health facilities. At the end of the 2 weeks, they return to a centralized location for a 1.5-day final synthesis of the course. As earlier highlighted, Similarly, trainers follow them up to provide mentorship support during the self-study period. This training course is delivered in 28 days. And one of the advantages is it's still cheaper compared to the 11-day and equally minimize disruption in service delivery. Also key to note is that the phased nature of the training aided learning for the participants. However, the major limitation was that it was challenging to organize mentorships and support all healthcare workers within the 2 weeks of self-study. All in all, it was used in 31 out of the 146 districts, and a total of 1,258 health workers have been trained to date using this model. Here is a picture of nurses at Naguru Hospital in Kampala conducting a self-study. In considering which model to adopt, Ministry of Health together with WHO conducted an evaluation to guide decision-making on scale up. And these methods were used as shown below. This slide summarizes the results of the evaluation. What this shows us is the proportion of cases correctly managed by each training model and the districts that this was tested in. We also see that the short interrupted and distance learning model both achieved the national threshold for cases correctly managed, which was 50%. However, the computer-based model did not achieve that. In terms of cost, the average cost of training and mentoring using the distance learning and short interrupted is about $541, which cost reduces the higher the level of care that you go because of the shared training costs amongst the more numbers of training participants involved. We see the cost drivers listed on our extreme right, including venue, among others. From the evaluation, Ministry of Health approved both distance learning and the short interrupted course for scale up of IMNCI across the country because they both met the threshold of correctly managing children. I'll talk about the lesson 2 that focuses on sustaining training gains through quality improvements. In service delivery, in service training only gets you so far. What is really critical is for health workers to institutionalize what they've learned from these trainings into routine practices and adapt them to their daily context that they experience. One of the key things for USAID supported sites, including Kampala site supported by the USAID Maternal Child Health and Nutrition Activity, is that they've worked with Ministry of Health to incorporate quality improvement projects on IMNCI practices to ensure that learners translate knowledge into practice. Listed below are some of the many change packages implemented at site level. However, key to note is that these are site-specific based on identified gaps. In terms of additional lessons learned, we see that district involvement is critical because district teams are mandated to conduct mentorships and support supervisions as part and parcel of their roles. Hence, this calls for the need to equally have their capacity built in terms for sustainability. Then also the mentorship approach used as well as utilization of WhatsApp groups to aid interaction between the learners and the trainers has potential to build strong and more localized mentorship networks. Last but not least, the component of on-site training is advantageous. And this is because health workers practice what they learn in real life settings, or even better in settings that they're already familiar with. And this equally minimizes disruption of work. In terms of unfinished business, we have persistent challenges, including irregular support supervision, suboptimal quality of care, and commodity stockouts. Hence, this requires a whole system strengthening approach to sustain training gains and improve child health as a whole. In conclusion, modifying the training delivery to achieve critical numbers of trained health workers, combined with integrated quality improvement approaches, enabled this scale up of IMNCI in Uganda. Also key to note is that quality improvement helps health workers to sustain training gains. Thank you, and over to you, Professor Peter.
Thank you so much, Agnes. I'm quite excited because I remember when all these modules were being developed, I was working with Jessica as part of this initial process. Although I've not been involved that much, I think it is exciting that they have led to scale up and perhaps made a major contribution to Uganda's progress in reducing child mortality, as indeed you showed in the first graph, which I would request that you put up. I'm going to get to the panelists. Dr. Bodo, tell us about the introduction of alternative IMNCI training delivery models in Uganda. What are the key considerations for selecting a suitable training model, especially at this time in Uganda? What would you say is the most relevant? Because like DICAT is not recommended here, but maybe access to computer and gadgets like that has improved. So what is your say on what is a suitable training model, and is suitable for where? Over to you, Dr. Bodo.
Yeah, can you hear me?
Very well, thank you.
Yes, thank you, Prof. Wise, and thank you. Really, IMCI lies at my in my heart, and so when we talk about IMCI and child survival, that's something that I really like to talk about. One thing we must note is that the background to WHO exploring alternative training delivery models was the fact that the scale up and the cost associated and the disruption of services that was occurring because of taking away health workers from their workstation was proving to be too much. And in fact, in the IMCI evaluation that was done, the strategic review of child health programming that WHO undertook about 2016, 2017, clearly showed that in many countries, including Uganda, IMCI have not been fully scaled up. So what are some of the considerations that we should be looking at? One definite is the cost. What cost would it translate into if you bring in, would it be cheaper? You brought in these alternative IMCI training delivery models. There are costs around, if you must have seen in that slide, for example, it showed that it's probably when you're implementing distant learning or short interrupted course, if it was at health center 3, the cost seems to be slightly more. Why? Because you're talking of one person in a health facility, and then each need a facilitator to go in there. So looking at the cost of what you're going to, the method that, the alternative method that you're going to look at, and the context, it becomes quite important. So cost implication and looking at the cost versus the number reached becomes very important. The second one is around the staffing. You know, you must have noticed that the training will take more than the usual 6 days. So over a period, probably somewhere between 1 month to 3 months. So you need to have a dedicated pool of mentors who will go out there and make sure they are there all the 3 months. So if you don't have such a large pool of mentors, and then you start the process, then you're probably going to stop along the way, and the participant will not complete the course. So having considered the staffing available, the expertise, the experienced mentor to be able to sustain the process over the whole period when the participants are being trained becomes important. The third one is really access technology, and you've already hinted on it. If you're going to use ICAT, which requires computer, and then you're in a setting, let's say, for example, in Uganda, around the northeast, a very rural setting where you don't have those facilities, then it will not work. And so looking at the context and balancing where it's more suitable vis-a-vis where it not be suitable becomes very important. And access technology is one key such area concerning rural versus urban. The other issue that you also need to consider which is extremely important, is the other additional infrastructure. And we're talking of things like power that should be available. We are also talking about if you're going to have participant clustered around or congregate around a central point or a central health facility. Other things like being able to watch some of those videos on their own, to be able to see the skills and then practice becomes extremely important. So those other additional infrastructures becomes very important. Also, the other bit is the type of learner that you are talking about. We are talking of in-service versus pre-service. That is extremely important. If you're going to implement this in the in-service, are you going to have students spend 3 months learning on the same thing when they have other things, or would you go for the 6-day course, finish it, and then you know they have other things to do? So so in-service versus pre-service. Then the other thing is if also still on the type of learners, we are talking of people who are technology savvy vis-a-vis the older people who would not cope if you are going to take them to use a computer for learning. So again, those become very important, and you need to probably choose. You probably need to consider having a variety of these training delivery methods, but segment it to the group that will be very suitable. So those are some of the key considerations that I think becomes extremely important. But ultimately, beginning with analyzing the cost, additional cost that you would incur, would really give you a guide on how to implement the decision. Of course, the last one that I forgot to mention is the acceptability, the engagement at the very start, because for work-based learning, the people, the health managers managing these participants have to accept to give them the additional time, and they have to believe that this learning works. Otherwise, the participant will not have the time to learn, and so you will not get the intended result of skills building. I think I'll stop here.
Thank you so much, Dr.
Thank you.
Thank you so much, Dr. Bodo. And for the panelists, there are some questions in the chat. Please respond to them as appropriate. I'm going to turn to Dr. Jessica Nsungwa, whom, as I said, is basically considered the mother of IMNCI in Uganda and the region. She also did her PhD around the same work. Dr. Jessica Nsungwa, based on your experience in Uganda, what challenges will countries likely meet and need to address when introducing alternative IMNCI training delivery models, and indeed training delivery models in general? Dr. Jessica.
Thank you very much, and nice to have all of you here. I think one of the things which Agnes has been able to confirm to us that it's actually feasible to reduce the time for training, and this training is effective. And it's also possible to decentralize this training. However, I think one of the key things we should be mindful about is the issue of protecting the time for clinical skills. I think we need to make sure that the people who are taking on this training need to make sure that the time for hands-on training, clinical training is protected, and ensuring that participants are actually exposed to a good number of cases to see. We know that some cases these days have become rare, like diarrhea, and you may need to have more innovative ways of making sure that these people are exposed, including using simulation models. I know we have the videos and so on, but there may be a need to have extra materials like simulation models, skills labs to support this specialized training. The other thing is also, in case these participants actually are not able to get enough exposure, we may need to think about accrediting them before we send them off or sign them off, and maybe even recall them for some refresher training, given that these trainings now have been brought closer to the community. The other important thing is to make sure that whereas we have modified the training, that the standards for having a quality training are maintained, that we have the right number of data per ratio per participant, which is there's a big temptation to think that because people are going to self-reading, we can actually reduce the mentors, leave alone the fact that mentors will vary. You need to think through how you're going to train these mentors, but also be able to accredit them. Not every person can be a mentor. And especially when you decentralize the training, you need to have to deal with those challenges and to make sure that if the success of this training really depends on the mentors we can have. The other thing I think is also to think about what exactly happens in the interaction phase. I think you need to have very clear instructions. Agnes talked about the culture of reading, but also being able to do self-reading on their own. Many of these health workers will be continuing with their work in the facility, and we need to make sure that we sustain the momentum. You may need actually to be more innovative. In Uganda, for example, a number of these trainers actually established WhatsApp group so they could actually support each other. So peer-to-peer support managed to help them to sustain the training, but also making sure that during the interruption training, it's a good system to document. Participants are given diaries to document what they do so that you can actually come and backstop at an appropriate time when you come to the mentorship. So I think that phase of the interruption is very, it has to be detailed out systematically, but also make sure that the participants have that needed support. The materials, the adaptation of the materials should not be actually arbitrarily adopting directly from a Leventhal course. I think we need to have clear evidence. One of the things we want to maintain is the skills building component, the clinical skills building component. But again, we know we want to shrink the training because we want to have it in a shorter period, leave alone having most of the reading being done by the participants. So you need to have a very structured process and maybe pilot these trainings, test these materials out without losing the good content in this material. Finally, I think the other thing we need to talk about, the monitoring tools. This training will need slightly different monitoring tools given the design, but also making sure that you're not only monitoring the participant, but the mentor to participant relationship, the contacts, the interaction they're having. So we need slightly different tools which can help us to visualize what is happening, but also be able to support the trainers. We have also had a bit of challenge because people have realized that these trainings can be modified. There's been an increasing demand for us to expand this training to the age group of 5 to 9 years. Some of these conditions like malaria now have shifted the older age group, and there's been a lot of concern and pressure for us to expand this training. So that is one of the things also you have to keep in mind. How are we going to do that older age group? There's lesser malaria in the under 5s, lesser diarrhea, but we're seeing more malaria, especially where the prevalence has gone down. We're seeing epidemics in the old age group, and it becomes very difficult for you to say, we're going to hold on this training. So we need to come in again with evidence, working with the WHO to modify and explain what we are going to do for the age group between 5 to 9 years. Thank you very much.
Thank you so much, Jessica. So she is emphasizing the importance that we can't just run with it. We need to continue understanding it and to ensure that when we deliver, we still have the standards. For the panelists, their questions in the chat. Dr. Jessica, Dr. Bodo, and others, please respond to these questions that people have asked. I'm going to turn to our third panelist, Dr. Emmanuel Mugisa, who works for USAID here in Uganda. Given USAID's long history in supporting the rollout of IMNCI in Uganda and elsewhere, what are your key takeaways as a key development partner representative for scaling up IMNCI? Dr. Emmanuel, what should we be doing going forward? What have you learned from this?
Yeah, thank you very much, Dr. Peter. I appreciate the submissions from my predecessors. I think as USAID Uganda, as a major development partner, I think one key takeaway that I'll bring to light is that among the USAID supported countries, we have seen that there's been some significant reduction in deaths associated with pneumonia, diarrhea, and even malaria. And if I can just quickly quote, I think since 2012, we've seen about a 28% drop in deaths from pneumonia in the USAID supported countries, and also about a 29% drop in deaths associated with diarrhea, again, among the USAID supported countries. And I think even at national level, we see more or less the same reductions between 2012 and 2021. But as USAID Uganda, we work very closely with implementing partners And one of our guiding documents is what we call the MCHN Roadmap 2030 strategy, which outlines a number of key shifts in programming for maternal and child health. And the focus really is on working with implementing partners, including IMCI, but also strengthening localization and private sector engagement. In Uganda, again, we work very closely with our partners in ensuring that, one, they focus on capacity building of key stakeholders at national, district, and health facility level. And much of the focus is really on using data to inform interventions. And this data is based on, what is collected at facility and also at community level. And the approach that we support together with the partners is the quality improvement approach, really for purposes of ensuring that there are innovative ways of identifying root causes to some of the preventable deaths, but also developing tested changes and harvesting learnings from these CQI projects. And the advantage you have with CQI projects is that they focus on facilities and communities that have the biggest burden of some of these preventable causes of death under child health. In addition, USAID Uganda contributes to health system strengthening through support towards clinic systems for supply chain, but also systems for monitoring and evaluation. And to wrap it up, I'll also just say that Uganda is among the 25 USAID priority countries which are targeted for support to minimize under 5 deaths from preventable childhood diseases, in line, of course, with our Ministry of Health goal, but also in line with SDG 2030. Over.
Thank you so much, Dr. Mgisa. And I like so many things, especially the last one, that Uganda is one of the 25 countries that USAID is going to continue supporting to further bring down child mortality. And I hope, and I advocate for going beyond survival. We need to also ask for USAID support in areas of thrive and transform. So there are a couple of questions in the chat that, but before that, I'm going to be reading out these questions. We still have a bit of time according to our technical officer. I'm going to ask Dr. Jessica and Bodo, and perhaps anybody that already you've mentioned, and Agnes presented it, but also Jessica, you said it, and also Emmanuel, that child mortality has been going down, that some conditions are even rare. I was so excited to hear that even to see the area is rare, which is a good thing. Congratulations. If child mortality is changing, and also context is changing very much, if places like Kampala, we have an oversupply now of specialists, doctors, pediatricians, and more. Is this the time to rethink IMCI in some contexts so that we're able to address some of the causes of child mortality that perhaps are contributing? I know we said it is malaria, but already we said malaria is going down. Pneumonia, we said pneumonia is going down. What else is killing children? Are there some more things that IMCI currently does not address? And also we are talking about child health redesign. Is this the place to also to rethink the strategy, integrate this in IMCI and use the same model? So I'm going to actually start with, let me start with Dr. Jessica, because you've already championed these kind of strategies. What is your take for this call to for Child Health Task Force to accelerate the progress further, which might mean that low-hanging fruits are gone, maybe even some of the conditions that IMCI addresses are increasing and becoming fewer, and maybe the other condition that we are not covering. I mean, one of them, of course, is neonatal health. Good enough is part of IMNCI, but has it been well covered in the strategy that Uganda is implementing? Or is this an area you need to strengthen? Are there other things that need to be improved? Do we need to advance IMCI? Dr. Jessica.
Thank you very much. And I think, as you said rightly so, there's been a transition and the conditions, but also there's been a reduction in some of the common childhood illnesses. In Uganda, for example, sickle cell disease is actually surpassing some of these conditions. And they've been a big problem because then we need to train our health workers, not only to treat, to identify these children, but also chronic care. Chronic care for these sickle cell disease patients is required. For neonatal health, I think one of the biggest challenge, whereas we have a sick child approach entry point, we also need to think about normal babies. Things like resuscitation need to be included. We have areas like post-discharge care. We know that some children, especially newborns, the number of babies who die maybe even be equal to the number of babies who die in the facility. So we need to design post-discharge mechanism for us to be able to predict children who may die, but also design a very specific follow-up system for these discharged babies, especially those we think are going to be at high risk. We need also to move away from the issue of survival only and move to the issue of early childhood development. We've already started a process of seeing how we can integrate this. I know WHO has some guidance on this, but this needs to happen because as more babies survive, then we need to make sure that many of them are able to thrive. So there are many things we can actually capture here. But also, as you said, some of the technologies which are in place, we may need to think about some of these things. We register, self-care is becoming a very important thing here, home treatment, and so on. So there is room for us to look at this whole concept, but also be able to tailor it to specific areas. Not everything will apply to every place. We may need to have some geographical consideration. Thank you very much.
Thank you so much. So we need to continue generating the evidence. It seems the moderator has actually given us up to 1 hour, but he is warning me, I mean, he is updating me on time. There are a couple of questions. Catherine Hill is asking, thank you for...
I could come in on the same question.
Okay, could you comment, Dr. Boda?
Yes, thank you, Prof. Waswa. I think IMCI still remains relevant, but we need to look at, and you know, the evaluation that was done, I think, showed that IMCI was like contributed about 15% or something to reduction in child mortality. There are many other things that probably also contributed, but we should look at IMCI as one of the structures within the overall programs available to reduce child mortality. You know that IMCI was specifically designed for the outpatient and then referral to inpatient. There is the WHO strategy of ITAT, which looks at those critically ill children. So we need to strengthen that as well alongside with the IMCI to be able to deliver quality care. But also we need to be looking more beyond the coverage. What is the quality of the services delivered? And that's why WHO came up with the quality of care I mean the global initiative for improving maternal, newborn, and quality of care for children. But I think what is very important is the issue of segmenting the population. And later, as we progress, as we have got more health workers, I think the regulation also will later come in. Who can deliver what kind of service? If you have additional health workers that can deliver the quality of service. Right now, we are saying everybody trained IMCI should be able to treat children, but you know that they're not working in vacuum. So all that segmentation of where IMCI would best fit vis-a-vis where there are more other qualified health workers who can be able to deliver more advanced care for those that have non-IMCI conditions. So all this need to be taken all together to be able to reduce child mortality. Over and back.
Thank you. Thank you so much, Dr. Bodo. In other words, you're agreeing with Dr. Jessica that we still need to advance IMCI. In fact, one of my colleagues, Dr. Rebecca Nantanda, said that not all of fast breathing is pneumonia. I think about 30% of the children she sees, 30 to 40% have an asthma syndrome. So I think we need to further advance IMCI. There is a question from Catherine Hill, and she's thanking you for a good presentation. And she had two quick questions, and if anybody is able to answer these, please. Is IMNCI included in the pre-service training for any of the health worker cadres targeted in the evaluation? Did the statutory trial intervention include any regular monitoring of a small number of IMCI quality of care indicators? So that's a question from Catherine here. And then from Humphrey, she's asking, how is possible serious bacterial infection and IMCI training platform prioritized, considering that Uganda's overall under 5 mortality is hugely affected by staggering newborn mortality? Please, somebody could think about that. There is a question from Raz: how can some of the training that is required be part of continuing medical education and licensing? And is there experience with digital algorithms to promote fidelity of case management of training? So let me first pause here and invite any of the panelists to answer this, please. Who would like to have a first go?
Yeah, maybe I could go first.
Okay, please, if you could please go ahead.
Yeah, so to this first question, which is IMCI included in the pre-service training? Yes, like the presentation was made, IMCI was, I think, about 1998, 99. IMCI was actually integrated into pre-service training. However, over the years, the implementation has not been uniform, as we have more new training institution come up, and the mushrooming training institution that have come up over the years. Some of them have not been doing it, but yes, this was done. But however, as part of the evaluation only targeted in service, so there is no experience of using these alternative training delivery models in pre-service. And in fact, and there was definitely a rigorous process of following up the participants during this pilot phase in the 4 districts that underwent short interrupted course and a quality assurance or quality improvement intervention was included. And that's why probably we saw those very high results. We definitely need to see what to follow up and see with the rollout, what is the result that we have seen. Is it also as good as what was seen during the pilot phase? That's something question that remains to be answered. And for PSBI, which is the guidelines for management of possible serious bacterial infection in newborns where referral is not possible, we actually included this as part of the IMCI chart booklet within the newborn section. And we are actually delivering this package as part of the IMCI training. We did not implement it as a separate kind of intervention in the country. I think I'll stop here and allow my co-panelists to answer the additional question. Okay. Thank you.
Thank you, Dr. Bodo. Anybody also wants to comment on that among the panelists? And for those, we are accepting a few questions in the comment section, and also to invite panelists to respond to some of those questions because we may not have enough time. Dr. Jessica, Agnes, or Emma, any comments? Dr. Jessica?
Typing in the chat on some of these issues, there was a question of supervision, and it has been included as part of the district IMCI tools. Yes, this is part of the IMCI, so the district supervision tools, but we know that districts have a broad spectrum of things to supervise. So from time to time, they select an area of emphasis or focus. And for child under 5 children, IMCI is the tool they use for supervision. Has this been evaluated? Yes. Some places we have had some evaluation, but one of the lessons we have learned is that for the transfer of learning to be very effective, health workers need to be followed up as early as 2 weeks initially to support them to get started, but also to support them to get support and engage the team in the facility. So yes, and then you can stretch out the other subsequent supervisions, maybe on a quarterly basis. So that initial follow-up has been found to be very impactful for these health workers. Sometimes when you do supervision, you may not find patients. So for the newborn, for example, we are able to use some of the simulation models which have been provided through the HPB training, but we need again to be more innovative to make sure that actually health workers can be observed or tested on some of these skills. The training also has involved the private sector. And I think the key thing here is that the private sector prefers to do the training on their own, but also to integrate the supervision within their broader activities. The health workers in the private sector also prefer to be trained during the weekend. So some of these trainings are staggered over a long period, and that has made it very feasible for them to share with us. And we do supervision with them in these facilities.
Thank you, Dr. Jessica. You've answered the private sector question too. Would you comment on how strong is the newborn component in the IMNCI? There's a question from one of our panelists. If you could do comment on that, Dr. Jessica.
Okay, so the newborn component, of course, our entry point again is a sick child. And over the years, WHO has been able to validate some of the symptoms, which actually has been very, very effective for us. I think here, like I said earlier on, we need to look at the component for follow-up of these babies. We have a hospital in Kampala here, where we've been following up premature babies born in that hospital. And we've actually found that 9 babies died in a span of only 3 months, just from one hospital. So there is a team of people who are supporting premature babies. Some of them are people who also had prematures, and they brought this to our attention. So we need to make sure that whereas these babies leave the health facility, we need more continuous follow-up of these babies, and if possible, refer them back for care. The other thing I think we need to think about, I think Dr. Boda talked about it, having piecemeal training. We could organize to have the HPB training fall on the IMCI training, but there's a need to make sure that there's a close linkage, and people who have been trained in IMCI or PSPI, if possible, should also have skills in doing HPB plus. And some of the components actually relate to the IMCI training, breastfeeding, and so on and so forth. So I think it's very important we should be able to strengthen the newborn component. There is the whole area of sepsis management, infection control, in terms of health system strengthening, which we also need to consider in the newborn component, because we're also seeing out of nosocomial infections in some of these newborn care units, because now there's also an expansion of special care units and newborn care units. So we need to evolve this training to be able to cater for that need.
Thank you. Thank you so much. That was a question from Lady Kirk, who is based at USAID. We also have a comment from John Brazo, who is one of the champions in the global child health, and he's saying that every country will have its own child health profile and priorities. Some countries like Uganda have actually are transitioning in the drivers in the mortality and need to address other conditions and age groups. So as countries these days actually have been talk about mortality transitions and analysis for maternal health, child health, newborn health, and actually IMNCI also need to transition in some of the countries. But other countries are still far behind. So the package that we have really works for those countries. So we need to apply IMNCI based on the context. I'm going to have to ask either Jessica or Bodo or anybody to comment on one thing, and then I'll summarize this panel, which is basically the role of some of these use of simulators. I know, Jessica, you've already commented on it, but we've used the neonatally and the mamanatally and others. What is the room for these in like the models that you have described in Uganda? One of you could just take 1 minute to answer that.
Okay, thank you, Prof. Waiso. Just to let you know that at the beginning of the process of piloting these alternative training delivery models, we actually explored had a learning visit to Mbara University that has got a skills lab, and saw the wonderful work that they were doing to use different models to facilitate learning. So yes, as technology advances, we think that should be an integral part of the learning process. Like Dr. Jessica said, some of the signs are even becoming rarer. So being able to demonstrate some of those signs, but also being able to allow the health workers to gain the skills, some of which would not be possible for the short contact session that you have, that the trainers have with the trainees. So in planning this alternative training delivery model, I think the budgeting, the costing, and all this additional technology that are required should be part and parcel of what you need to plan to be able to deliver quality training. Thank you, Prof. Waiso.
Thank you so much, Dr. Bodo. Agnes or Dr. Mugisa, any last comment?
I just wanted to answer the question about whether some indicators are tracked, quality of care indicators. Yes, there are tracer indicators that are tracked to measure progress made in implementing the various quality improvement projects. And these are recorded in the QI database that is housed at the Ministry of Health. So just to answer that is a tracked. But all in all, it's key to ensure that we innovate and address barriers to scale up of various trainings. And in particular, this is IMNCI in the country. Thank you and over.
Thank you. Emmanuel, your last word?
Yeah, thank you. I just wanted to point out, I think one of the comments that has come from my colleagues, especially on the neonatal deaths. I think as a country, Uganda, we see that there's a lot of traction in terms of, auditing these deaths right from facility level to district level, but also at national level. But I think we are still a little bit slow on utilizing that information to improve care. So I think at the end of the day, what we need to do with the MPDSR reports is really to utilize that information to inform decision-making and also to understand what continues to kill these newborns and acting on those key interventions to ensure that we minimize deaths. Thank you.
Thank you so much. So I would like to conclude to say that there is a lot to learn from Uganda's story of scale up with innovations in training modules and the delivery mechanisms. And IMCI is still needed, but we need to perhaps contextualize it to mortality transitions, either in the country or even within the country, because things are changing rapidly. But we also need to consider cost, feasibility, and the current causes of death. I always say that impact is equal to coverage times quality and equity. So we cannot just deliver without thinking about quality and the equity. Not coverage alone is not enough. And learning is going to be an important part of as we continue implementing IMCI. And we need also perhaps to think about going beyond survival to actually think about thrive. How can we integrate the thrive agenda within the scale up of IMCI and other interventions? So advancing IMCI, I think, is one of the things that we need to be doing. And IMCI has been a major contributor to countries' progress. For us from the Child Health Task Force, this documentation and learning together is important for countries. I would like to thank the panelists. Thank you, Dr. Bodo, Dr. Jessica, Dr. Manuel, and Agnes for wonderful presentations, discussions, and learning. And to you members who have joined to listen in, thank you for your contributions in the questions and the chat and for listening to us. Thank you. And from me in Kampala, Makere, good evening and good morning or good afternoon from wherever you are. Thank you and bye-bye.